Good afternoon, my colleagues. Many of the Good afternoon, my colleagues. Many of the faculty delegates who visited. We watched this 2 days program of PSP Academy, which I formed in the memory of my beloved father. And we have done a good number of CTO PCI, and 5 cases have been done in these 2 days. Uh, uh, 3 cases have been done anti-grade, and good techniques have been demonstrated, and good interactions from my colleagues, Dr. Raghu, Sharath Reddy, Purohit, Kasturi, and many other colleagues who participated, Shashikant, Narsaraju, everybody. So they contributed good interactions for this. It's for the benefit of the fellows and who are learning, who already learn, and still, after learning so many years, still we have to learn more in CTO PCI, which is being more important nowadays. Unlike previous, that CTO PCI is important to avoid bypass in most of these patients who deserve it for the benefit of quality of life to prevent arrhythmias and improve the LV function and many things. That's why in a selected case, CTO PCI is really worth doing. So I have a talk on this in the retrograde step-by-step approach. So in this, the hybrid CTO PCI AP algorithm, there are many algorithms are there, but many algorithms, everything says dual injection. Dual injection is the key, is common in all algorithms. That what you see in the dual injection is the ambiguous cap and distal objects and interventional collaterals, any side branches at the distal cap, and length of the CTO and calcium. Then you decide whether you do the antigrade technique or the retrograde. Yes, most of the cases have been done to integrate with the advancement of the CTO wires and the technology and the microcatheters. So imaging modalities, the IVAS. So we are doing more antigrade, but in selected cases, definitely retrograde plays major role. In the JC2, the Japanese registry also retrograde the higher end of the JSTO score, the success rate is more with the retrograde techniques. So if you want to be a CTO operator, you should know anti-grade technique. You should know ADR techniques, either wire-based or string-based or recross, or many methods are the base, creation, so many, and the finally retrograde. If you know all three together, then you are only complete CTO operator. For that purpose, these academies have been started. It will be done at regular intervals, which I will be specifying and intimating you in my mails and YouTube programs. This is score. Everybody knows JCTO score is formed based on the stump, the tapered and blunt tip, the calcification, and the bend more than or less than 45 degrees, occlusion length 20 to more than 20 millimeters, retry. Because most of the cases in dedicated centers like ours, we have a retry cases. So naturally JCTO score increases. But there are many other scores available, but this score still a fabulous score, which really doesn't include, like today I've done the left main CTO already stented, a stump plus. These things are not included. The comorbid things are not included, and many other things to be included in the JC2 score. So many scores have come up now, but still this JC2 has the importance. Why we should try the retrograde? Because the retrograde, the distal cap is a tapered distal cap, and the morphology pathology is soft cap. That's one of the reason. It need not be always a softer one, but mostly that's the reason we try the retrograde. And particularly, as I said, the length, the tortuosity, calcification, side branch, and distal bifurcation, particularly if you do RCA, if you find a PDA, PLV, good sized branch, the C2 ends at that segment, retrograde is always better because likelihood of subintimal entry of the antigrade wire and antegrade PCI at the bifurcation. That's why in these cases important. So what are the primary indications? Where you select only retrograde still is the ambiguity, proximal cam ambiguity. But now I was guided puncture has come up a long way to this indication and ambiguity I was guided puncture. But still, even I identify a ambiguous cap, a real world experience tells that we have to coordinate the IVAS image with the angiographical retrograde all together to puncture the cap. And most of the operators who do IVAS guided puncture also have to go to retrograde at some time because this is a difficult procedures. Just by seeing the image, you cannot puncture. Second thing is the bifurcation. As I told, if you see distal cap bifurcation, there the subintimal entry is very common, and you see a very badly diffused distal vessel where the outcomes in the antegrade is not good. And most important things is the anomalous vessels and the vessels having a flush occlusion. You see RCA stumpless. That's we are doing now. The RCA completely stumpless occlusion. Only way is we go from the collaterals, retrograde, snare it, and do it. That's the only way doing. Like today's one case we have done, and at the later stage after crossing we have to defer because of the long procedure and some pericardial leak we have seen that stage we have to watch the ACT take a decision. So the flush aortic occlusions are, and the most important thing is value. A retry cases, somebody tries antigrade approach recently. I'm not going to try antigrade in the case in a short period. I'll give 8 to 12 weeks time. If I have somebody asks me to do before that, I prefer a retrograde approach rather than an antigrade approach. So, what you should have in the in your cat lab when you are trying to first you try antigrade simple cases like a ready mid CTO or say mid CTO. Don't try circumflex CTO in the beginning because circ is always a different ball game. Left main circumflex angle. Even a normal PCI will have many problems, as you know. That's why try for the RCA and LED mid. These are the safer things and for a retrograde, after doing many CTO anti-grade with a proctor, then you can try the retrograde. Retrograde should have a good 7 French and 8 French systems. We are the radial dedicated center. Still, I prefer when I do retrograde, a 7 French femoral is more comfortable for the device delivery, navigating the devices. And you should have IVAS in your cat lab. That is your choice. A tip to transfer 20 millimeters is available and 2.5 is available. In Japanese lab, there is a tip to transfer of 9 millimeter Navi focus is available. Anti-wall catheter is available. Latest, so many advancements, they're also coming to India. We operate usually with a Boston Opticross or the Philips lab with a Olcon high eagle eye catheter. So the support catheters are key as the guiding catheter is important, the support catheters also. There are many support catheters like Corsair, the Corwell, Corsair Pro, Fine Cross. These are all catheters coming into a Mamba catheter, the tuck pine catheter. What difference exactly makes is that a hydrophilic nature. The tip difference in the tip size. So as the tip tapers, a taper tip with lower French like 1.8 French fine cross, a 2.1 Corwell. Like once that tip penetrating power will increase, the tapering tip comes and the hydrophilic nature. The hub, holding the hub, this is shaft strength. So these are the things which the upgradation of many catheters coming into the market based on this and visibility. Very important. You should see the visibility of the if you have don't have a good cat club, then the visibility of the this tip of the catheter is very important. Suddenly, the hydrophilic catheters can come out. You don't see anything. That's why visibility of the lab also very important. Then the wires for retrograde are any penetrating wire of the antigrade opt for the distal cap is one and the same. But the antigrade, the retrograde crossing is different. So once you have the microcatheter into a selected, like I am doing a LED C2 or PCI, I cross from a PDA to septal collateral to LED. Then I will enter the PDA in a different angles I check in a rotational angio or a different angle, see which is the best collateral of the guiding injection. And then I'll put the microcatheter, whichever of choice, like Corsair or Corwell. These are all 150 centimeter you have to have, not 135. So once the catheter reaches there, you can take the wires which have a, rope coil like thing, the cyan wires, cyan blue wires. These are initial entry into the collateral is very good wires. But the wire of choice for me is always the CO03, which really is a tree-shaped tip and a very atraumatic wire, which is more important when you tackle the collaterals. So once you track close to the catheter, to the wire, only in epicardial collateral, we keep a little distance. But in this, we keep very close and cross the collateral to the vessel which you are likely to open. And this the low profile, once you cross, what happens is you want to externalize with some other RG3 wire and all. After that, you have to do a dilatation of the low profile. For antigrade or retrograde low profile balloons, many are available. The balloons of Alveo have come with 0.75. Nano balloon has come 0.85. And there are many balloons of 1 millimeter. Sapphire balloons are Sapphire 2 has come. The Riviera balloons of Termo, I really like them, even 1.5. So there are many balloons coming into the market with low profile, taper tip, hydrophilic. These are characters of these balloons. And whenever you have this, you should not have too much bleeding. That's why the push-pull Y connectors, some of the companies have got a very good Y connector. So less blood loss is the key here, long procedures. Then 2 cc liver lock syringe, very important. Whenever you aspirate blood from the microcatheter, you see that backflow is there. Never inject contrast when you don't have a backflow. There, the extravasation come, preparation chance is high. That's why. And in the beginning, you will try to avoid the procedure looking at the nasty images on the fluoro. That's why better avoid injecting without any backflow. Then you should have prepared for a trapping balloons. Now there's a guideline with trap balloons are there on the same catheter. So usually balloons have come with trapping balloons. They are 6 French compatible. You can do a simple PCI of CTO with 6 French with these balloons, and always have long DAs because most of the CTO say that you do antigrade or retrograde PCI. Ultimately, you're tracking false lumens, true lumens, false lumens, and long stents are happens a metal jocket in CTO PCI. Whatever you try to do, shorten the length, the long DS is very important. And coil snares, like a proctor, I go many places. I carry the coils and snare with my bag. These are very important. Need not send for surgery or anything. Just have either a cook delivery catheter or you can have a fine cross catheter and 8 French and halal coils of 2 millimeter, 3 millimeter. You can easily seal the septal collaterals in a simple technique. And the snares are nowadays less use of snares. Once the guideliner, gadgillas, these have come, the guide catheters, support mother and child technique, that's have come. The usage of snares have come up. Still, in cases where next case I am planning that absolutely there is no anti-grade stump. So on CT only we can see. These are cases where I have to snare it. So usually a gooseneck snare or E snare, a 20-25 millimeter snare is usual, and ACT monitoring. Exactly, very important. Now, when you are dealing with retrograde, you have to maintain around 350 because the ACT monitoring do it every half an hour and it's checked because thrombosis in the donor artery is catastrophic. That's why it is there. And IVAS, as I told, IVAS systems are must in retrograde. So, as I said, just do the angiogram and dual injections. This is the classical dual injection. If given caudal and cranial view, what you expect in dual injection, I told you already the length of the lesion, the calcium, and the ambiguous cap, distal vessel, the collaterals, all information you get in one, two shots, two angles of dual injection. This is fundamental thing every operator should do. And if they, as I said, ambiguous cap, CTO length, and the distal cap, landing zone. This is very important. Whenever you see the collaterals, how the entry and exit points are very important. If the entry and exit points are angulated, then there is always even it's a big collateral also. It is no. There are many classification of these collaterals, but some people give. I feel still feel size of the collateral is important. In many collaterals you see jungle of collaterals, mesh of collaterals, but none of them is useful for you. A large collateral, a subtle collaterals, entry exit point straight is the easy way of learning initial rather than doing surfing, which is sometimes risky. The interventional collaterals should be straight and entry exit points should be very clear, and the landing zone should be a little away from the cap. That's very important. To this gap between the cap and the collateral is important. How to navigate the microcatheter? There should be some space where you should navigate the collateral. Now the score has come up. For further score has come up to improve our outcomes. It looks at the vessel size, the reverse bend, and the continuous bends and corkscrew. So based on this vessel size, reverse bend, continuous bends, and corkscrew, scoring has been done. So in the both in the septal and non-septal. So if you find it zero, it is easy to cross. If you find intermediate 1 to 2 and difficulties more than 3, it's very important score, very useful. So if you see the ideal collateral is what I told just now, and how you predict the success. Location of the collateral. You see the proximal collaterals are always better. Don't tell the distal collaterals because the distance that microcatheter has to travel is more. The support needs is also more. Then you have to have a short guiding catheters of 90 centimeters. That's why locational collateral. A right view, not only everywhere. It's a toilet thing. You have to have a right view to locate the collateral. This is important, and don't go on changing the views many times. Select one, two views, and do that. A rotational angio also sometimes guide you whether you are in the correct track or not. Selective injection. Yes, once we enter with the microcatheter into the collateral, give a selective injection after getting a backflow. This is important. And once we enter the fine channel, you can give super selective injection to enter the main artery. So some individual collaterals also you can do, but direction of procedure is also important, whether you're going from PDA to LAD or LAD to PDA. So this is a septal collaterals. Usually you can see that maybe this is a CC1 collaterals joining entry and exit. With some you can see epicardial, very tortuous. They are very impressive, particularly from the circumflex going to the PLV, PDA. You'll be jumped on to try a epi. Never do that because these impressive things are catastrophic if it perforates because you have to close them from both ends and the tamponade comes very fast. That's why septal collaterals, even you stain it, you have some extra extravasation, nothing going to happen. Most of the cases, you observe it, but see that observation is important on the echocardiogram and the hemodynamics, anything. And if they are increasing in size, there itself in the cath lab, you seal it rather than trying to ship them and take them back next day. That is not correct. Like this exit from the donor artery is branching, very difficult. The stent struts, that's what exactly today happened for us. The stent struts are difficult if they are underexpanded stent, particularly. We have to dilate the struts and do it. Then the size of the connection, I told also, people may not give importance, but a good size always for you more comfortable. Tortuosity, explain the score, tortuous collaterals. You have to see in multiple views. That's why one view you see straight collateral, can see other tortuous, it can perforate if you pass the wire without observing. So I told already collateral to recipient artery. The distance is very crucial. If you have very short distance, microcatheter rotation navigation is difficult. And wire profiles we make depending upon the curves and from the main artery to the collateral. But the cheap 1 millimeter sharp curve keeps the wire in the lumen. This is important. Then sometimes use dual lumen catheters to enter the septal collators. For this, Sasuke is a very good catheter. It's a low profile. Crusade is difficult, but Sasuke catheter, we can enter the septal small branches from the main septal channel. So this is the way we enter from the struts, dilate with the struts with some 1.5 millimeter balloon, then enter the catheter. So suppose you find difficulty in crossing with the guide catheter, you choose a better larger guide catheter, it gives good support. Then sometimes you can use a guide extensions which give you good support. Sometimes you can use balloon anchoring techniques and the low profile microcatheters like sometimes fine cross goes very easily. Fine cross tip is little hard only, but many catheter doesn't go, fine cross and go. Nowadays this Corsair Pro XS has come with a lot of hydrophilic long hydrophilic thing, and some catheters need just push pull things. Some catheters need rotation, 10 rotations clockwise, anti-clockwise, like this. So change the microcatheter. And lastly, I think very important, you have to change the collateral also. Don't try the collateral repeatedly. If you are finding difficulty, there is something wrong. So stenosis may be there, which you are not able to visualize. And this is a classical septal collateral crossing where this support catheter, the initial wire is the cyan blue like wire entering the collator, then change to CO is a P-shaped wire and a traumatic wire it can cross. The other options when you find tortuous is cyan black, but I am little hesitant. I have a couple of occasions, small leaks with the cyan black. So today I also had this problem with cyan black. You have to be very careful when handling these wires in tortuous vessels. So this is a difficult Corsair negation. Yeah, as I told, change the collateral when you find difficult too much. And microcatheter distal site reach, then you have to penetrate the cap. There you need the tougher wire. Minimum 3 grams wire is ideal. Previously Miracle, but nowadays the Gaia wires have taken Gaia, Gaia next. And then the ultimate brass wires, the Gladius mango wire. These are the excellent wires which can penetrate the distal caps. So you have to have the wire crossing. Along the wire crossing, then your microcatheter also goes. Sometimes it's a true lumen to true lumen entry when you are entering the distal cap to the CTO segment, but it may not be happen always. Some 30% it can happen, but if it doesn't happen, what to do? The first step is the reverse cut. The reverse cut in the CTO segment. What you do in the reverse cut in the CTO segment, a small balloon, 2 millimeter balloon, you can take on the antigrade wire, which is in the subintimal space, and the retrograde wire also in the same space, dilate, and it is deflating. When it deflating, pass the wire antigrade into the guiding catheter. This is simple technique of reverse cut. Depending upon the size of the vessel, doing the IVAS, you can size the balloon. Sometimes use 2.5 balloon. Very rarely we use very larger balloons, but sizing is very important. Sometimes this reverse cut doesn't work. We have to have something called a knuckle wire technique. So knuckles can be formed either antigrade or retrograde. Retrograde knuckles also, while the wires of choice are the pilot wire, the Gladius manga wire, the Fielder XT wire, the cyan black. These are the wires for a knuckle. You can pass a knuckle. And previously we used to enter this after doing the reverse cut directly into the guiding catheter, but it is always safe. Suppose you find difficulty in getting into the guiding catheter, use what is called the guideliners or Godzilla, the support catheters. So this is the different types of reverse cut. What I told is the conventional reverse cut. The other thing is just in the long segment of CTO, once you like RCO CTO, you pass the antigrade Y to the distal until the distal portion of the CTO. Then that portion you have a small balloon and direct the retrograde wire. Usually the Gaia 2 is the favorable wire towards that balloon. This is called the contemporary reverse cut. This is a simple technique. And anything beyond the CTO segment, when you do, is called extended reverse cut. There you need the IVAS for doing. So these are the various techniques, conventional, directed, and extended reverse cuts. Then long CTO, I told you, knuckle wire is very useful. You don't cross the with very hard wires long distance without knowing where you are directing. This is very important. And retrograde wire positions, always see the IVUS catheter. So once you see the virus, now both wires in the subintimal space is very comfortable. Some in the intima, sub in the sub that is not comfortable. So these are the four types of retrograde and antigrade wire positions. See that both the wires in the same space. This is very important. Even you need some larger balloon. Sometimes you have to use. Then the externalization. The externalization wire is the RG3, the standard wire what we use, but FC wire also 300 can be used in some cases. This is a flimsy wire. You have to be careful. Once we externalize, you have to bring out from the other groin, taking out from the guiding to the Y connector and reattach the guide. Only important thing is we should not lose the tip of this wire, very flimsy. On the same wire, you can navigate your balloons and stents, everything. You have to be careful handling this very delicate wire. But RG3 is an excellent wire for externalization. Once you get the guiding catheter, the support microcatheter into the antigrade guiding catheter. So this is, as I told, the simple wire cross. In the beginning, if you find some channel, something not much calcium, you can enter a simple wire cross into the guiding catheter. And some cases where you find difficult guideliner, why guideliner? Suppose you are doing a left main entry, then if you wire is in the false lumen, your left main will be the subintimal stenting and the patient can collapse. The same thing can happen in RCA at the aortic ostia. So these guideliners see that this damage doesn't happen. It enters the guideliner very safely. So it gives support also. You can direct the wire. And once you are not able to get into the guiding catheter, the important thing is the snare. You can use, as I explained you, get into the brachiocephalic trunk area, then snare it out and push the guiding catheter to the ostia then and took the wire out. This is a simple way of doing things when you are not able to. This is a classical snare pull, what we have done in this case from the RCA. You are pulling out and reattaching the guiding catheter to that. So once this externalization has been done, once the RG3 wire, very important thing is when the perforations come, septal perforations, is the septal perforations can come when there is actually withdrawal of the equipment. The withdrawal of the equipment, sorry, the withdrawal of the equipment can happen when you are pulling out the RG3 wire. So never pull out these wires without the microcatheter support. When you pull out these wires, see that the guiding catheters are disengaged. This is important because the guiding catheters, either antigrade, retrograde, can suck in and produce dissections, which if you don't notice after shifting the patient, you can have problem. And always remember, at the end of the procedure, the donor artery injection should be done. See that all the perforators are clean, there's no leak, there is no increase in the extravasation. These things are important. And I said, withdrawal of the equipment is some steps to be taken in this. And check for the collateral injury. In this, I checked everything collateral injury. If anything need, just do the job on the in the cath lab and minimize the injury. That is very important. Stenting is done as any other cases, you know. Only thing is before stenting, these cases of CTO PCI may need some block modification, and you have to be careful in the CTO segment when you go to high pressures. You should avoid the perforations, and you should have a covered stents also with you when there's this is the final results what you achieve. Very important. Don't get disappointed by the distal vessels in these cases. Mostly in 6 months' time, all these vessels will grow mostly, and sometimes it can be spasm. And you check with the IVUS, you give some nitroglycerin, and these things will improve the vessel sizes. And see that there's no distal leaks. Small perforators can be which can cause slow perforation after 24 hours, still 24 hours. That's also important. Thank you. Thank you for hearing. And these programs will continue, and I'll be in touch with all the CTO interested people to upgrade ourselves in the technology and benefit most of the patients. Thank you.